Let's go over the warm-up review. First question, what are the signs and symptoms of excessive cholinergic stimulation? So the mnemonic is dumbbells, which stands for diarrhea, urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle and the CNS, lacrimation, sweating, and salivation. So remember, you get leaky everywhere. Leaky bowels, leaky bladder, tears, sweating, and drooling. Good times. Next, which psychiatric disorder is associated with decreased norepinephrine? That's depression. And the last question, patients who have migraines with aura are at an increased risk for what other neurological condition? They're at increased risk for strokes. Now let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on chromosomal disorders. Guys, this one is chock full of high yield stuff, so you better bring all 46 chromosomes along with you because you're gonna need them. In fact, borrow an extra chromosome from a friend for good luck. And if you don't know why that's a bad idea, then you better pay attention. Alright, so first we're going to talk about the autosomal trisomies. Now the three that you need to know are Down syndrome, Edwards syndrome, and Patau syndrome. So let's start with the big one, Down syndrome. Down syndrome, also referred to as trisomy 21, where you have all or part of a third copy of chromosome 21. Now Down syndrome is the most common of the trisomies, about 1 out of 700 live births. Now the findings include intellectual disability, that flat facies, prominent epicanthal folds, simian crease. There's an increased gap between the first and second toes. Now patients can have other things, duodenal atresia or a blind duodenal pouch. Down syndrome patients can acquire endocardial cushion defects, and the endocardial cushion defects may cause an ASD or a VSD or an abnormal connection between the atrium and the ventricles or an abnormal connection between all four chambers of the heart, because that's basically where the endocardial cushion is located. Now it's also associated with the increased risk of ALL and Alzheimer's disease. Now it's also going to have a bit of a smaller association with AML, but most questions are looking for ALL as the answer. Now, one way to remember this is with the Ring Around the Rosie song. Remember when you say all fall down. So all ALL is associated with Down syndrome. Now, there is a specific gene on chromosome 21 that is associated with Alzheimer's disease or dementia. And when you have 3 copies of that gene, unfortunately, you're more likely to acquire Alzheimer's dementia. Now, another pathology seen in Down syndrome is that 65% of newborns with Down syndrome have polycythemia. Now, Down syndrome is the most common chromosomal disorder and the most common genetic cause of intellectual disability. What is the number 2 genetic cause? That's going to be Fragile X syndrome. And then what is the most common overall cause of intellectual disability? It's actually fetal alcohol syndrome. Now, one way to help screen for Down syndrome is with the quad screen. Very important here. The pregnancy quad screen will include a decreased alpha-fetoprotein level, increased beta-HCG, decreased estriol, and increased inhibin A. So this is a series that is worth knowing. Let me repeat that. That's how important this is. Decreased alpha-fetoprotein, increased beta-HCG, decreased estriol, and increased inhibin A. Now, if you see that constellation on a pregnancy quad screen, it raises a flag for Down syndrome. Now, here's another great way to remember the labs in Down syndrome. Put the labs in alphabetical order, starting with Down and then alternate. So AFP down, beta-HCG up, estriol down, inhibin A up. Now, ultrasound in the first trimester is going to show something called an increased nuchal translucency. And just one FYI, you might also see this with Turner syndrome as well. Now, 95% of these cases are due to maternal non-disjunction during anaphase of meiosis 1 of homologous chromosomes. Let me repeat that one again. That's another high-yield one. Mostly caused by maternal non-disjunction during anaphase of meiosis 1. And this non-disjunction is associated with advanced maternal age. The risk of Down syndrome is actually pretty small in younger age women delivering children, but as you grow older, specifically older than 35, the risk starts to go up. And then over 45, the risk is even higher. 1 out of 25 live births will have Down syndrome over the age of 45 with maternal age. Now, 1% of cases are due to Down mosaicism, where there's no maternal association at all. And again, mosaicism is where not all of the cells are identical. Some of the cells will have trisomy 21, some of the cells do not have trisomy 21. So that's mosaicism. So let's move on to another concept here, Robertsonian translocation. So about 4% of Down syndrome cases are going to be due to a Robertsonian translocation. So a Robertsonian translocation is a very unique phenomenon. It's a non-reciprocal chromosomal translocation that commonly involves chromosome pairs. So one of the most common types is where translocation occurs when the long arms of two acrocentric chromosomes fuse at the centromeres, and the two short arms are then lost. So you're left with really a very long chromosome, and it's really long chromosome, and it has all the important genetic material of two chromosomes really put into one. And though these people only have 45 chromosomes at that point, because you've lost the short arms of these, you can actually turn out fine. There's no major loss of genetic material, and they just have a normal phenotype at that point. But in the case of Down syndrome, we see a Robertsonian translocation between chromosomes 14 and 21. So they make a really big long chromosome that has the genetic material of 14 and 21. And for that first child, you may not have any problems. This might be a normal situation. The child will have 45 chromosomes, but all the important genetic info is still present. But that next generation might develop a gamete that has the mega 14/21 combo chromosome and a regular chromosome 21. And then when that gamete joins with another gamete that has a regular chromosome 21, then the result is 3 copies of chromosome 21. So that's what we're talking about with this Robertsonian translocation, where the long arm of chromosomes are fused with another chromosome, and then that is passed on through the germline. And so that 4% of cases of Down syndrome can have from that, because you're getting 3 copies of 21. And this is, again, one type of mutation causing that Down syndrome, but it's not associated with advanced maternal age. Very important there. Okay, so now let's move on to Edwards syndrome, or trisomy 18. It's about 11 times less common than Down syndrome. Now, one way to remember that it's on chromosome 18 is that Edward has 6 letters and trisomy is 3, so 6 times 3 is 18. So patients will present with severe intellectual disability. They're also going to get what's called rocker bottom feet and micronanthia, so undersized jaw. You're also going to see some clenched hands, prominent occiput. That's a big, huge clue as well. Death, unfortunately, usually occurs within 1 year of birth, and this is the most common trisomy resulting in a live birth after Down syndrome. Now, what would you see on a quad screen, or sometimes you'll get a tri screen on this one? So you would see decreased beta-HCG, so that's different than with Down syndrome. You would see a decreased alpha-fetoprotein, a decreased estriol, and then potentially a normal inhibin if you actually tested for it. So basically, everything is decreased, but the inhibin A is going to be normal. Nuchal translucency could be seen here as well. And then we have Patau syndrome. Patau syndrome is trisomy 13, even rarer than Edwards syndrome. You have similar things again: intellectual disability, rocker bottom feet, microcephaly, cleft lip, and cleft palate. One of the unique things with Patau, a hollow prosencephaly is that single midline eye that can happen here as well. That is also associated with defective sonic hedgehog gene. It's also associated with polydactyly and congenital heart disease. Also with this one, death usually is going to occur within 1 year of birth. Pregnancy screening here would reveal a decreased beta-HCG, but then you're also going to get something called the decreased PAPPA. So pregnancy-associated plasma protein A, it's a mouthful there, and increased nuchal translucency as well is also possible. You can't use the second trimester quad screen to detect trisomy 13 effectively. You may see a slight decrease in estriol, but you can see abnormalities in that first trimester combined test. All right, so let's review now some of these serum markers and the trisomies in another Lewis Notes. All right, guys, it's time for another Lewis Notes, and we're looking at our trisomies today, and we have to look at our quad screen or some of our early screening tests that we can do. This is pretty high yield stuff. They love to put in these things because they're confusing, because some are high, some are low, and you have to know the pattern. So the first one here is our trisomy 21. That's going to be our Down syndrome. What are we going to see here? Well, first we're going to look at our alpha-fetoprotein. We're going to see a decrease in alpha-fetoprotein. Next, what are we going to see on beta-HCG? This is going to be increased, so put that there. For estriol, we're going to have another decrease here in regards to that. And then for inhibin A, we're going to have an increase. Now, what about trisomy 18? This is our Edwards syndrome. So here we're going to see a little bit of a different pattern here. We're still going to see a decrease in our alpha-fetoprotein. Our beta-HCG is going to be decreased. So that's where we're going to see one of your first differences here between here and trisomy. For estriol, we're going to have a decrease again. And then for inhibin, this is going to be normal. Now, what I would probably do for our trisomy 13 is Patau. So one thing you really have to kind of realize here, though some of the same tests are going to be used, we're actually not using quad screen. So don't use quad for our trisomy 13. You actually have to look at some earlier testing in order to get something out of your screening in order to look for trisomy 13. Now you're still going to see a decrease in beta HCG. And the other thing you can look at is you can look at this PAPPA thing here, and that's for pregnancy-associated plasma protein A, and that's going to be decreased as well. So that's one way you can look at this. Now remember, you can also see a nuchal translucency. You can see that in trisomy 21 and in trisomy 13. So look for that nuchal translucency in those two as well. So if you can remember these patterns here, I'm pretty confident if you just know this level of detail, then you're bound to get the question that they're going to ask you on step 1 regarding this stuff. All right, that's going to be it for our trisomies. All right, so next we're going to talk about our sex chromosome disorders, and this is a 4-star topic. You're going to have a question on probably either Klinefelter or Turner syndrome or both, so make sure you know the ins and outs of Klinefelter and Turner. Very high yield. So first let's start with Klinefelter syndrome. So this is a genetic disorder where you have an extra sex chromosome. So instead of our usual 46XY, you're a 47XXY. So there's another, if you want to think about it, another female chromosome, another X chromosome thrown into the mix here. Now, one way I like to remember the characteristics of Klinefelter is that this is a male, so it's an XY with an extra X chromosome. So this is going to have maybe more female-like qualities with that extra X chromosome. Therefore, these patients will have testicular atrophy, which will lead to decreases in testosterone. And without much testosterone, these males will have less muscular bodies, less facial hair, less body hair, broader hips. They're going to be tall, they're going to have long extremities, maybe some gynecomastia, and there might be some female hair distribution as well. Now, they may have the presence of what's called the inactivated X chromosome. This is called the Barr body. So whenever you have 2 X chromosomes, really only one of them is active. So here you have 2 X chromosomes in Klinefelter, one is inactive. Now, males are often infertile or may have reduced fertility. Other problems will include dysgenesis of the seminiferous tubules, which will lead to decrease in inhibin. And then with that decrease in inhibin, you may see an increase in FSH or follicle stimulating hormone. So let's now talk about Turner syndrome. The incidence of Turner syndrome is 1 out of 3 to 4,000, and the chromosomal abnormality here is 45XO. So you're actually missing that other sex chromosome. You just have one X. Now, affected patients, as you would expect, are all female because there's no Y chromosome here. So are they going to have a Barr body like we saw in Klinefelter? Well, no, they just have one X chromosome. There's no inactivated X chromosome here. So how does this present? Well, patients will have short stature, sometimes even less than 5 feet. They're going to be broad-chested, sometimes referred to as a shield chest. You're going to see a low hairline, low set ears, and webbing of the neck is also very interesting. Now, patients will have gonadal dysfunction, which results in amenorrhea and infertility. So this will sometimes be referred to as streak ovaries. So Turner syndrome is the most common cause of primary amenorrhea. Cardiovascular involvement can include a bicuspid aortic valve and preductal coarctation of the aorta. Now, there's classic Turner syndrome, which is everything that we've just described, but a lot of women that have Turner syndrome don't know that they actually have it because many of the physical manifestations are much more mild than what we've just talked about. Some women will present to the office, maybe even just in high school, because they've never had a period. They don't have those typical physical findings. They just haven't had a period yet. So you always want to rule out Turner syndrome in anyone with primary amenorrhea. Now, if you look at hormones, then you'll see decreased estrogen, which then leads to an increased luteinizing hormone and increased follicle stimulating hormone. Now let's move on to the double Y males, another sex chromosome disorder, those double Ys. So it's kind of like Klinefelter, but instead of an extra X, now you have an extra Y. But these patients are phenotypically normal. They tend to be pretty tall, though. They can have severe acne. One controversial issue is that the presence of antisocial behavior. So there was a study at one point that looked at criminal inmates, and they found that there was a higher likelihood of double Y males in criminal inmates than there was in the general population. But that study in and of itself doesn't prove causality. They do have normal fertility. There's also some possible association with autism spectrum disorders as well. Next, we have Cri-du-Chat syndrome. So Cri-du-Chat syndrome is the next one. This is a relatively high yield for step 1, so make sure that you know about this. It's actually pretty easy to identify on most test questions. Patients are going to have microcephaly, moderate to severe intellectual disability. So several of these diseases that we covered today are going to have that microcephaly and intellectual disability. The manifestation that gives this one away is that high-pitched crying and sometimes referred to as mewing sounds that the patient's going to make. So that's pretty unique to the Cri-du-Chat, thus the name. name cry of the cat syndrome. Patients will have epicanthal folds as well, cardiac abnormalities, but they almost always have to say something about a high-pitched cry or mewing, like a kitten with that cri du chat. That's kind of your tip-off for step one. Now, the genetic cause for this syndrome is a 5p deletion. So there's a missing part of chromosome 5. And this may also be actually referred to as a chromosome 5p deletion syndrome. Next, we have Williams syndrome. Williams syndrome, think about Will Ferrell on this one. He was in that movie Elf. So the findings you have here is distinctive, what we call elfin facies, intellectual disability. You're also going to see hypercalcemia, and this is going to be due to a hypersensitivity to vitamin D. These patients actually have pretty good verbal skills, and what's also interesting is they're very, very friendly. A lot of friendliness even with strangers. Now, this is due to a microdeletion of the long arm of chromosome 7. Again, think about Will Ferrell in the movie Elf, Williams syndrome. That's a good clue for you there. And then the last one we have to talk about are the 22q11 deletion syndromes. So these syndromes are due to a heterozygous chromosomal deletion at that 22q11.2, get very specific there. And those 22q11.2 syndromes include things like DiGeorge syndrome and the velocardiofacial syndrome. Clinical manifestations can be pretty variable. It can include things like cleft lip, abnormal facies again, thymic aplasia resulting in T-cell deficiency, cardiac defects, hypocalcemia due to parathyroid hypoplasia, and it's specifically associated with those thymic and parathyroid cardiac defects. So a lot of variability there. All right, guys, that brings us to the end of the video part. It's time for that end of session quiz. Try to answer those first, and then we'll go through them together. First question, what prenatal ultrasound finding is a clue that the fetus may have Down syndrome? Well, this isn't particularly specific, but nuchal translucency you might see in a Down syndrome, but it might also be seen in some of the other trisomies as well. Next question, what is the most common event that causes Down syndrome? Is it meiotic non-disjunction, mosaicism, or the Robertsonian translocation? Well, it's going to be that meiotic non-disjunction, and more specifically, it's the maternal non-disjunction during anaphase of meiosis 1. Next, what are the clinical features of Williams syndrome? So remember, you get that intellectual disability, you get those classic elfin facies or effects that can be present on the face. They can get the unique feature of that friendliness and that strength in verbal skills, especially with strangers. And then you can also see some cardiovascular defects, usually valvular defects. Next, what are the possible defects in cases of chromosome 22q11 deletion? So a lot of variability here, but you can see that abnormal facies, cleft palate, you got to remember, thymic aplasia, hypocalcemia, and cardiac defects. Next, what are the distinguishing characteristics of Klinefelter syndrome compared to Turner syndrome? So remember, Klinefelter occurs in males who are genetically XXY. They have that extra X. They are potentially tall with long extremities, testicular atrophy, gynecomastia, more female characteristics. Turner syndrome occurs in females who are XO, so they lost a chromosome. There would be here short stature, webbing of the neck, a shield chest, and some primary amenorrhea as well. All right, guys, that brings us to the end of session quiz. Now, we do have a couple rapid fire facts. First one here, most common genetic cause of intellectual disability, remember, Down syndrome. Second most common genetic cause of intellectual disability, that's going to be Fragile X syndrome. Horseshoe kidney, congenital heart defects, streak ovaries, and cystic hygroma. That should make you think of Turner syndrome. Rocker bottom feet, clenched hands, microcephaly, prominent occiput, small jaw. That's going to be trisomy 18 or Edwards syndrome. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.